Hi, everybody, and welcome to week 9. This week, we're going to look at value, waste, and observing process. So, this week, your book talks a lot about waste and values. The first thing I want to review is waste in healthcare. In 2012, the Institute of Medicine stated that a third of healthcare costs, over $765 billion, is wasted. Now, some of this is in things like fraud or lack of access, lack of health insurance, but the two areas where we can make change is inefficiently delivered service and unnecessary service. When we talk about waste in healthcare, there's a couple phrases that are key to watch out for. One is when you hear things like, we can't change the process. Question why is definitely worth asking. We are in a regulated environment, and we're going to talk in a little bit about whether we can remove all of the non-value added services. But it's always worth asking, why can't we change the process? And if we can't completely overhaul it to make it better, is there ways to make small changes that would drive improvement? The phrase that you need to be a little more careful for is, this is the way we've always done things. Um, there's a lot of reasons why people are resistant to change, and you're going to talk about that in your discussion boards. Um, but that phrase, "this is the way we've always done this," is something you really need to be careful. And sometimes I found when working with employees and asking, when I see a process that's very convoluted or potentially unnecessary, I'll keep asking them why. And ultimately, sometimes they get down to this answer, which is, this is how I was trained to do it, or this is why we've always done things. And then I can say, okay, great. Well, let's research why we're doing this way. Let's research into the problem a little bit and find out if this is the best way, because this could have been the way you were trained and it may have been the best way at that point in time, but now it's time to reevaluate a process. On the flip side of this, we're looking at value. So what drives value in healthcare? It's really defined by the customer. And it's important to remember in healthcare that the customer could be many different people. Quite often, and the most easiest one to explain is the patient. So if you're the patient, what is value to you, right? There's monetary value, of course, the value of getting safe, effective care and having it delivered to you in the location and at the time that is convenient to you. That's becoming more and more important. We saw this huge spike in telehealth this year. It's not going to go away completely. There's times that I think it's great to be able to just do a telehealth visit really quick or have my doctor call me. I love patient portals that I can communicate with my doctor, especially if it's something really quick or about a medication. And just to know whether the doctor's saying, oh, you should come in for that, or, oh, we can make some modifications basically over email, which is fantastic. Saves me time from work, having to leave and go visit somebody for, maybe a 10-minute in-person interaction when that could have been done over email. It wasn't pressing. Um, Other people that could be the customer for you, if for the operating room, our customers are the surgeons as well. So are are we giving them appropriate access into our operating rooms? Are they having to wait a long time? How can we improve our process so that the surgeons can come in, do their surgeries, and leave because they have other obligations, like being in their office? And if they're caught up in the operating room, then they can't be in the office to see patients there. So think about who your customer is in any given situation when you're reviewing a process, and try to look at the process from their perspective. Sometimes it's about setting expectations as well. We deal with this a lot with surgical discharges. We're trying to improve our process to get patients out sooner if they're stable and ready to go, to try and keep our hospital beds open for those people who need them. A lot of times patients do not want to be discharged at 7 o'clock at night, or they don't have somebody to get them even though they may be ready to go. So the difference between having a patient stay overnight and get discharged at 7 a.m. versus 7 p.m., that's somebody waiting in the ED overnight now that didn't get a bed, that's stuck waiting in the emergency department. So preparing a patient and saying, as soon as you're ready to go, whether that's 7 or 8 or 9 o'clock, you may be going home. So sometimes it's expectation setting as well. So how does lean look at value? Lean has 3 criteria to prove value. One is that there has to be payment for activity. Um, this may, when you look at lean outside of healthcare, it's that the customer has to pay. Obviously, we're dealing with insurance payment methodology, so things get a little more complicated with healthcare, but there has to be some sort of payment for lean for it to be considered of value in lean. The activity must transform the product or service in some way. So this is the step I think can get a little complicated. The activity must move the patient closer to their ideal health and quality of life. So this could be giving the patient education, this could be prescribing medications, really anything that's working with that patient to advance them closer to their ideal health, actually performing a surgery or a procedure. Um, and the activity must be done correctly the first time. A very extreme example of this would be if something was left in a patient, if a sponge or an instrumentation was left in the patient, and you have to now open the patient again, bring them back to the operating room, use a time that's being taken away now from somebody else, to go back in and open that patient and remove the sponge or whatever was left in them. So accuracy is also very important. Non-value added activities, these are activities that get done that fall into that waste categories. They're not adding value to the product, to the process. So obviously something like a defect, that would not be a value added. Overproduction, having more than you need. In the operating room, we have our sterile processing department, which brings up all the kits for the next day, that are going to be used in surgery. So we know in this room you're going to do 3 hip replacements. So they may have 3 case carts of equipment ready to go for 3 hip replacements. They're not going to make 5 case carts. That would be silly. Where would we put them? It's a waste of resources. They could be working on something else. So overproducing to the point of um, just having extraneous supply for no good reason is not going to help. Transportation, unnecessary transportation. So if somebody can move 2 case carts at once, but they're taking one at a time and going all the way up and all the way back. One of the ways we reduce this. So speaking of our sterile processing department, we have 3 main buildings in our hospital. Sterile processing is in one of those buildings, not the building with our main operating room. So, um, most of the time that's fine. They can send all the dirty equipment down there. The problem becomes when you have maybe 5 of the same procedure happening in a day, but we only have 3 kits, which would normally be okay because we do case 1, it goes back down into sterile processing. We start reprocessing that for case 4 immediately, so that that can come back up. One of the issues we were having was with the transportation of the equipment, being able to get it back and forth to the operating room. So we actually created a minor sterile processing turn center in the footprint of our main operating room so that in those situations they can turn over those kits really quickly and significantly lower the amount of transportation that they were having to take. Waiting, this is a big one. Um, and then you're looking at it from the process side, right? So if you think of a standard doctor's office, the patients that are waiting are not always considered in this process because the goal is to make the best use out of the provider. So if the provider is the resource you're trying to maximize, you want that provider to have patients lined up, room 1, 2, 3, 1, 2, 3, and they're going to just keep bouncing back and forth because what we're maximizing is the use of the provider. Now, as healthcare has morphed over the last few years and become a little bit more patient centric, we're starting to look at things like how can we notify patients, alert them of wait times? Is the provider behind? So they were really not put into the thought process, especially when you think of a standard doctor's office on how to limit wait times from the patient's perspective. It was how to maximize the resource, and in this case, the resource is the provider. So the patient waiting was kind of not really thought about now that we have more patient centric and patient surveys and kind of the yelping of medicine, if you will, and we're getting more of the strive for 5 kind of star deals. It's become more and more important. Whether that's good that that's the driver or not, I guess, is debatable. But that's the reality: is that now we're starting to look at patients and say, okay, well, how do we don't want to waste their time either. So how can we let them know when we're behind? How can we let them know? Make sure that we're bringing them in accurate times. Inventory, you don't want to have too little, you don't want to have too much. So finding that sweet spot, and those of you who have backgrounds in inventory management and materials management and supply chain, that's kind of an entire course and program of study in and of itself. Obviously, we're seeing some supply chain issues right now with everything that's happening out in the Port of Los Angeles and Long Beach, where we're seeing some supply chain issues happen there, which have trickle down effects. Here in Massachusetts, there was for months, nobody had like large cups like at Starbucks or anywhere. You couldn't get a large cup. Everybody was out of them. So just like a weird supply chain thing. Motion, you wanna make sure that staff has access to what they need, where they need it, not just when they need it, but where they need it. So constantly having to leave one physical location to go here, to go there. Your book talks about people walking miles in a day to get their job done. Over processing. So this would be putting so many checks and balances into a process that it's been over processed. Sterile processing, are you putting too many things in the kits and then they're only using one piece of instrumentation and now you're re-sterilizing 5 additional things even though only 1 was used, because once that kit's cracked, the whole thing has to be re-sterilized. So is there a way to put less instrumentation in the kits? If they really only need access to 1 instrument, maybe we need to unbundle some of those kits. So that would be something that would be an over processing example. And then human potential, waste of talent. So if you have people that have skills and they're not being used to their potential, they're going to leave, and then you have to incur the costs of hiring and training, and you're losing some of your institutional knowledge when those folks leave. Obviously, we're seeing that in the market right now with they're calling it the Great Resignation. So, kind of fascinating to watch that one play out on a huge, huge scale. What we're seeing right now. Um, can we remove all the non-value added steps in healthcare? No. And the reason is because we're highly regulated. We've talked about that before. So if giving blood, for example, 2 people have to check that, right? In lean, you would say, well, 1 person check the blood, it's fine. 2 people have to check blood bands before blood can be infused because it's such a high risk procedure. So sometimes because of safety and regulatory requirements, we have what in other industries would be considered a wasteful step. So those sort of things would have to stay and have to be in your process because they're required for what we do. So just keep in mind that sometimes healthcare and the nature of it will lend itself to being a little bit wasteful, but we can certainly do a better job. And there's a lot of examples where we can do much better. So next we're going to talk about value stream mapping, just for a little bit, and then I'm going to show you some examples. I'm going to make a spaghetti diagram for you live because I want you to see one way to make one. There's many others, but I'm going to show you kind of a simple way that you can make one in Excel, because I think when you look at them, you're like, oh my goodness, how am I going to do this digitally? Um, and I want to show you actually a copy of a value stream map that we're using on a project at work. I hope all these work examples are helpful. I think seeing a live one from industry is probably the best example I can give you. So you guys are going to know everything there is to know about Bay State Health by the time the semester's over. So a current state map, and that's what I'm going to show you, is mapping out exactly what it says, mapping out the current state of a process. So your book has some really good examples. They actually give you a surgery example on the bottom of page 76, where when you think about everything that has to happen for a patient to come to surgery, um, it's a ton of steps, from the decision of a surgeon to have that patient have surgery, to scheduling the surgery, to going through your preoperative testing and getting all your clearances. And then you have to go through your pre-op process, and then you go to the operating room, and then you go to your PACU or the recovery room, and then you finally go home, or you go inpatient, then you go maybe go up to the floor and you could go inpatient. You're inpatient for a couple days. So it's this huge process with many, many, many steps. That's actually what the process map I have to show you, and in just a minute, is our pre-op process. So just everything that happens prior to coming to surgery. So it would be helpful to look at, if you haven't already, the map at the bottom of page 76, because what I'm going to show you is a much blown out version of just one portion of that, and how we're trying to make that better. A future state map would take that current map and then make the necessary changes. So you'd be working with ideally an interdisciplinary team to make that better, to make the plan better. How can you improve the process? Because sometimes when you see it written out, you realize, holy moly, this is a lot. And most of the time, the players involved in these processes only know their piece of it. And so when you really look at everything, you can start to realize why somebody's job may get more tedious or slightly more difficult for the betterment of the entire process and the entire project. Next, we're going to observe the process. So one of your homework this week is going to be to make a spaghetti diagram, which I'm going to show you. So that's really observing somebody's movements. Um, there's a famous one. I couldn't find a succinct YouTube video of it. There's a very famous Kaizen process about making toast, and basically it's a gentleman who is going to make toast for his wife, and he does, he walks over to the cabinet and he gets the bread and then he puts it in the toaster, and then he takes the bread and he puts it back, and he takes all these kind of wasteful steps to make the toast, and then it comes out and he butters the toast, and then it's not even what his wife wants. And so then when they redo it, he does it in a way that he gets it in the toast first, gets the toast in the toaster first, and then spends all that wasted time of him kind of standing around, because in the first one there's a lot of him like waiting for this toast to be made. In the second one, he does all of the walking around of putting the bread back and getting the butter out, all happens while it's there. And then he actually washes a load of dishes while he's waiting. So it just goes to show that if you redesign when you do tasks, you can get more done in the day. So there's more of a focus now on designing nursing units to make there be less steps for the nurses, physical steps, so that they get what they need. Certain things being kept in the patient's room so they're not constantly going to a supply closet. Um, Anything they can do to make it easier on the nurses and less steps on the nurses, because that's not, they are there to work at the top of their license, which is to provide direct patient care. And if they're not doing that, then you're not utilizing the resource, which is their nursing expertise, in the best way possible. We can kind of get into EMRs, and I'm sure some of you will, whether we're overcharting or we undercharting. Our EMRs made it better? Have they made it worse? We're not going to get into a ton of that now, although I kind of hope some of you do in the discussion board, because it's a fascinating discussion about what do we capture, what do we have to capture. We talked about data last week. If we don't have the data, we can't measure it. But where's the value in having your front end nurse enter some of this information? So EMR is what we capture, how we capture is going to be a battle and a topic of conversation for a long time. So now I'm going to show you these first. So this here is let me scroll to the top. So this is our pre-surgical pre-op clinic redesign. So the reason this came up, at least in my job, is our pre-admission department or our primary care was actually seeing a huge influx of patients needing surgical clearance. And so we realized that we can do better through pre-admission, that we were sending too many patients to their primary care and cluttering them. So in here, you can see the surgeon's office. So referral to the surgeon's office, the patient checks in, the patient completes paperwork, which varies by the office. Surgical consult occurs. The surgeon's office speaks with the patient and so they right here is the decision to have surgery. Now the office is going to speak with the patient. They identify probable surgery dates. The surgeon's office completes and sends a booking sheet to the contact center. So for us, the contact center is our centralized scheduling. We have a massive call center that everybody schedules through. Once that happens, now we're into the contact center. So you can see one of our lean experts actually did this for us. So you can see she's got this stratified into the surgeon's office, contact center, and then the pre-surgical team. So now the contact center schedules the surgery in SurgiNet, which is we're a Cerner shop. So that's the surgery module within Cerner. The contact center has practices permission to contact the patient. So some offices allow that, some do not. So if yes, the contact center will contact the patient. If no, the contact center sends the date back to the office. And then either the contact center will call the patient and they book their pre-surgical appointment and give them information, or the practice calls and does this. Now we're into the pre-surgical team. So the pre-surgical evaluation nurse does a phone assessment and completes information in CIS, which is Cerner Information Systems. Recommendations, instructions are manually written out and sent out via email or the postal service. So we send information to the patient. Direct patient to get labs drawn in certain intervals at our lab order. So whatever is necessary, the nurse, the pre-surgical evaluation nurse, will give that information to the patient. Based on the phone assessment, then they determine whether this patient rises to an acuity level where they have to see medicine, the Department of Medicine, for clearance, or anesthesia before the surgery. So most of our patients fly right through. If you have a history, so at least on the anesthesia side, if you have a history of problems with anesthesia, if you have trouble breathing, we would want to see you. So then, yes, then the ambassador will contact the patient, schedules these. Patient arrives at Chestnut, which is our outpatient building, and they go to, then you can see the registration workflows. There's another workflow. At this point, they monitor the patient chart for completion. Is the patient optimized? So this last check happens to make sure that everything's in the chart that needs to. Is the patient optimized? Yes or no? If yes, then call the patient and relay final instructions. Did the patient answer yes or no? And then we get into our day of surgery workflow. So all of this happens before the patient even steps foot on our campus. So as you can see, this is clearly multidisciplinary. All of this is a whole team that happens before the patient even steps foot onto the campus where we do surgery. And then we have our whole contact center and their workflows, and then the surgical's office and their workflows. So this is just an example of a project plan, what it looks like. I wanted to show you kind of a larger one. She actually did a couple different versions for us. I'm not going to waste your time going through them all, but she did do, it's not scrolling great. But she did a couple versions for us on what these might look like. So I hope that's helpful, just kind of seeing how they would look in when you're actually working on a project. And then the last thing I want to show you guys is a very quick way to make a spaghetti diagram technically. So the spaghetti diagram is monitoring your flow of anything, a person, how they're moving through this. So you can do them in Excel. I like to, first thing I'll do is go to page layout and move my face. And under alignment, I'll pick snap to grid, and it just helps me keep my shapes a little bit better in order. Then I'll go to insert. And I don't know if you guys have the same version as I do, so I may be using a newer version. So under illustrations, these used to not be nested under this illustrations tab. So you guys might see these, if you have a slightly older version of Excel, you'll just see these out in your ribbon. Under shapes, and pick whatever shape you want to use. Rectangle is kind of the most common. So let's say we're going to do this toast experiment, right? So I'm going to draw what my kitchen looks like. So I have a back counter. Okay. Oh, hold on, this isn't snapping. Hold on. I bet I turned off snap too. Let me try this again. Insert, illustration, shapes. Well, never mind. Okay, so this would be my back counter. And then I'm going to insert another one. And here's my stove. Okay. You can also copy and paste these. So if you wanted another shape that was the same, I can copy and paste and I can rotate it. So let's say that this is my island. I'm going to make it a little. All right. And then copy and paste. So this is make this more like a square. So my kitchen table. Okay. You can label these. So if you go in, you can right click and hit edit text. And I'm just going to say kitchen counters. And you could do whatever you would do with text normally. So let's say we want to make it bigger. I want to center it. I want to make it bold. Okay, cool. So you can label them all however you'd like. So you lay out your diagram, whatever it is you're trying to diagram. So if I'm gonna, again, I'm doing this toast, I'm gonna map for you how I make toast. I'm gonna lay out my kitchen. So if you're doing your nursing center, you would have, maybe your patient rooms, and then the nursing desk here at the center, and you could have what's around you, but it can absolutely be how you get ready in the morning, how your bedroom is laid out. This does not have to be work related. You can process map anything you want. And then to actually do the map, also under insert and go into shapes again, you want this guy. So under lines, this one at the end, if you hover, it's going to say freeform scribble. This is going to let you draw. So if you click that, you're going to get a little pencil. And so then you can start to map out your process. So you can say when I come into my kitchen and I set things down on my kitchen table, and then I go to my counters and I get I get the bread, and then my toaster's over here and I put the bread in the toaster. And then I come over here and I get a plate, and then I set the plate on the island. And then I go back over here and get a knife. And then I put the knife on the island. And then I go to this cabinet and I get the peanut butter and I put that on the island. And now the toast pops up. So now I get the toast. And now I come back to the island and then I bring it to the table. So that's going to be one. You can do different colors. You can do each one of those separately depending on what you want to see. And then when you write this up for me, you're going to write up what this meant and you're going to send me a copy of this file. So I'm going to be able to see your map and I'm going to see the steps that you laid out for me. So this one doesn't have to be in APA format. I hope it's a little bit fun to be able to go through the process map and kind of see how many movements you're taking, even if you're doing something as simple as how to make toast or how to put away your laundry or whatever it is that you're trying to process map. So this is just a really simple way to do a process map in Excel. Without having to have anything fancy. Now, if you have access to Visio or Minitab or Lucidcharts is great. Those are all really great software products that help you make these types of maps. So if this is something you're going to do, Lucidchart is a great one that it's not, it's, you think you can have three, you can get a free version where you can have three process maps in there. But you don't have to do that for this project. This Excel is fine for what you're doing here. And if you're not going to be doing this a lot, you don't need to. But if this is something you're going to do, look at learning how to use Visio, Lucidcharts. Visio is the Microsoft one that comes with the more expanded Microsoft suite. So I hope that was helpful. If you have any questions, please let me know. And I will see some of you on Tuesday. Remember, lecture this week is on Tuesday instead of Monday because I have a conflict. So I hope to see some of you on Tuesday. And thank you so much for watching.